Complications of positive pressure ventilation. Although PPV may be essential to maintain ventilation and oxygen, it can cause adverse effects. It is often difficult to distinguish complications of mechanical ventilation from the underlying this disease. Cardiovascular system. PPV can affect of circulation because of the transmission of increased mean airway pressure to various structures in the thorax. With increased intrathoracic pressure, thoracic vessels are compressed. The compression causes decreased venous return to the heart, left ventricular end diastolic volume, preload, and result in hypertension. Mean airway pressure is further increased if PEEP is being titrated, greater than 5 cm H2O, to improve oxygenation. If the lungs are non-compliant, example ARDS, airway pressures are not as easily transmitted to the heart and blood vessels. Thus, effects of PPV on CO are reduced. Conversely, with complaint lungs, example COPD, there is increased danger of transmission of hideaway pressures and negative effects on hemodynamic. Compromised venous return by PPV is worsened by hypovolemia, example hemorrhage, and decreased venous tone, example sepsis, spinal shock. Restoration and maintenance of the circulating blood volume are important in minimizing cardiovascular complications. Pulmonary system barotrauma. As lung inflation pressure increase, risk of barotrauma increases. Patients with compliant lungs, example COPD, are at greater risk for barotrauma. This results when the increased airway pressure distance the lungs and possibly rupture fragile alveoli or emphysema tube labs. Patients with stiff lungs, example ARDS, who are given high inspiratory pressures and high level of PEEP, greater than 5 cm H2O, and patients with lung abscess resulting from necrotizing organisms, example staphylococci, are also susceptible to barotrauma. Air can escape into the pleural space from alveoli or interstitium and become trapped. Pleural pressure increases and collapses the lungs, causing pneumothorax. The lungs receive air during inspiration but cannot expel it during expiration. Respiratory bronchioles are larger on inspiration than expiration. They may close on expiration, and air becomes trapped. With PPV, a simple pneumothorax can become a life-threatening tension pneumothorax. The mediastinum and contralateral lungs are compressed, reducing co-immediate treatment of the pneumothorax is required. Pneumomediastinum. It usually begins with the rupture of alveoli into the lung interstitium. Progressive air movement occurs into the mediastinum and subcutaneous neck issue, and pneumothorax often follows. Unexplained subcutaneous emphysema is an indication for immediate chest X-ray. Pneumomediastinum and subcutaneous emphysema may be too small to detect on X-ray or clinically before the development of a pneumothorax. Volutrauma. The concept of volutrauma in PPV relates to the lung injury that occurs when a large VT is used to ventilate non-compliant lungs. Volutrauma results in alveolar fractures and movements of fluids and proteins into the alveolar spaces. Low-volume ventilation rather than pressure ventilation should be used in ARDS patients to protect the lungs' alveolar hypoventilation. It can be used by an appropriate ventilator setting, leakage of air from the ventilator tubing or around the ET tube or tracheostomy cuff, lung secretions or obstruction, and low ventilation/perfusion ratio. A low VT or respiratory rate decreases minute ventilation. This results in hypoventilation, atelectasis, and respiratory acidosis. A leaking car for tubing that is not secured may cause air leakage and lower VT lungs. Secretions can cause hypoventilation. Mobilizing the patient, turning the patient at least every 2 hours, encouraging deep breathing and coughing and functioning as needed, may limit this. Increasing the VT, adding small increments of PEEP, and adding a preset number of signs to the ventilators, that is a deeper than normal breed incorporated into the respiratory cycle, can help reduce the risk of atelectasis. Alveolar hyperventilation. Respiratory alkalosis can occur if the respiratory rate or VT is set too high, mechanical overventilation, or if the patient receiving assisted ventilation in hyperventilating. It is easy to overventilate a patient on PPV. Particularly at risk for patients with chronic alveolar hypoventilation and CO2 retention. For example, the patient with COPD may have a chronic PaCO2, elevation acidosis and compensatory bicarbonate retention by the kidneys. When the patient is ventilated, The patient's normal baseline, rather than the standard normal values, is the therapeutic goal. If the COPD patient is returned to a standard normal PaCO2, the patient will develop alkalosis because of the retained bicarbonate. Such a patient could move from compensated respiratory acidosis to serious metabolic acidosis. The presence of alkalosis makes weaning from the ventilator difficult. Alkalosis, especially if the onset is abrupt, can have additional serious consequences, including hypokaliemia, hypocalcemia, and dysarrhythmias. Usually the patient with COPD who is supported on the ventilator does better with the short inspiratory and longer expiratory time. If hyperventilation is spontaneous, it is important to determine the cause and treat it. Possible causes include hypoxemia, pain, fear, and anxiety, or compensation for metabolic acidosis. Patient who fight the ventilator or breathe out of synchrony may be anxious or in pain. If the patient is anxious and fearful, sitting with the patient and verbally coaching the patient to breathe with the ventilator may help. If these measures fail, manually ventilating the patient slowly with a BVM 100% oxygen may slow breathing enough to bring it in synchrony with the ventilator. Ventilator-associated pneumonia. The risk of for health-associated pneumonia is highest in patients requiring mechanical ventilation because the endotracheal tube or tracheostomy tube bypass normal upper airway defenses. In addition, a poor nutritional state, immobility, and the underlying disease process, example immunosuppression, organ failure, make the patient more prone to infection. Ventilator-associated pneumonia is pneumonia that occurs 48 hours or more after endotracheal tube intubation. It occurs in as many as 27% of all intubated patients, with half of the cases developing within the first 4 days of mechanical ventilation. In addition, patients who develop ventilator-associated pneumonia have significantly longer hospital stays and higher mortality rates than those who do not. In patients with early ventilator-associated pneumonia, within 96 hours of mechanical ventilation, sputum culture often grows gram-negative bacteria, example, Escherichia coli, Klebsiella, Streptococcus pneumoniae, Haemophilus influenza. Organisms associated with late ventilator-associated pneumonia include antibiotic-resistant organisms such as Pseudomonas aeruginosa and oxacillin-resistant Staphylococcus aureus. These organisms are abundant in the hospital environment and the patient's gastrointestinal tract. They can spread in a number of ways, including contaminated respiratory equipment, inadequate hand washing, adverse environmental factors such as poor room ventilation and high traffic flow, and decreased patient's ability to cough and clear secretions. Colonization of the oropharynx tract by gram-negative organisms predisposes the patient to gram-negative pneumonia. Clinical evidence suggesting ventilator-associated pneumonia includes fever, elevated white blood cell count, purulent, odorous sputum, crackles or wheezes on auscultation, and pulmonary infiltrates noted on chest X-ray. The patient is given antibiotics after appropriate cultures are taken by tracheal suctioning or bronchoscopy and when infection is evident. Guidelines on ventilator-associated pneumonia prevention include minimizing sedation, including daily spontaneous awakening trials, SATs, and daily spontaneous breathing trials, SBTs, early exercise and mobilization, use of endotracheal tubes with subglottic secretion drainage ports for patients likely to be intubated greater than 48 to 72 hours. Hob elevation at a minimum of 30 to 45 degrees and less medically contraindicated. No routine changes of the patient's ventilator circuit tubing. Prevention also includes a strict hand washing before and after suctioning, whenever ventilator equipment is touched, and after contact with any respiratory secretions. Always wear gloves when in contact with the patient and change gloves between activities, example, emptying urinary catheter drainage, hanging on intravascular drug. Lastly, always drain the water that collects in the ventilator tubing away from the patient as it collects. Sodium and water imbalance. Progressive fluid retention occurs after 48 to 72 hours of PPV, especially PPV with PEEP. Fluid retention is associated with decreased urine output and increased sodium retention. Fluid balance changes may be due to decreased CO, which in turn results in diminished renal perfusion. Consequently, renin release is stimulated with subsequent production of angiotensin and aldosterone. This results in sodium and water retention. It is also possible that pressure changes within the thorax are associated with decreased release of atrial natriuretic peptide, which also causes sodium retention. Wild water retention is also associated with PPV. Less insensible water loss occurs through the airway because ventilated delivered gases are humidified with body temperature water. In addition, as a part of the stress response, release of antidiuretic hormone and cholesterol contributes to sodium and water retention. Neurologic system in patients with head injury, PPV, especially with PEEP, can impair cerebral blood flow. The increased introductory positive pressure impedes venous drainage from the head. The results in jugular venous distension. The patient may have increase in intracranial pressure due to the impaired venous return and subsequent increase in cerebral volume. Elevating the HOB and keeping the patient's head in alignment may reduce the harmful effects of PPV on intracranial pressure. Gastrointestinal system patients receiving positive pressure ventilation are stressed because of the serious illnesses, mobility, or discomfort associated with the ventilator. Displaces the ventilated patients at risk of developing stress ulcers and gastrointestinal bleeding. Patients with a pre-existing ulcer for those receiving corticosteroids are at an increased risk. Any kind of circulatory compromise, including reduction of CO caused by positive pressure ventilation, may contribute to ischemia of the gastric and intestinal mucosa and possibly increase the risk of translocation of gastrointestinal bacteria. Stress ulcer profile access, including giving histamines, H2, receptor blockers, example ranitidine, proton pump inhibitors, example omeprazole, or eternal nutrition to decrease gastric acidity and reduce the risk of stress ulcer and hemorrhage. The use of personal protective equipments may be linked to an increase in the development of Clostridium difficile-associated diarrhea. Gastric and bowel dilatation may occur because of gas accumulation in the gastrointestinal tract from swallowed air. The irritation of an artificial airway may cause excessive wear swallowing and subsequent gastric dilatation. Gastric or bowel dilatation may put pressure on the vena cava, decrease CO, and prohibit adequate diaphragmatic exclusion during spontaneous breathing. Elevation of the diaphragm as a result of paralytic ileus or bowel dilatation leads to compression of the lower lobes of the lungs. This may cause atelectasis and compromise respiratory function. Decompression of the stomach is done by inserting an OG or nasogastric tube. Immobility, sedation, circulatory impairment, decreased oral intake, use of POID pain medications, and stress contribute to decreased peristalsis. The patient's inability to exhale against a closed glottis may make defecation difficult. As a result, the ventilated patient is at risk for constipation and a bowel regimen should be started. Musculoskeletal system, maintenance of muscle strength and prevention of problems linked with mobility are important. Adequate analgesia and nutrition can enhance exercise tolerance. Plan for early and progressive mobility of appropriate patients receiving positive pressure ventilation. In collaboration with physical and occupational therapy, perform passive and active exercises, maintain muscle tone in the upper and lower extremities. Simple maneuvers such as leg lifts, knee bends, quadriceps setting, or arm circles are appropriate. Prevent contractures, pressure ulcers, foot drop, and external rotation of the hip and legs, by proper positioning and the use of specialized mattresses or beds. Use a portable ventilator or manually ventilate the patient with a BVM 100% oxygen when ambulating. Psychosocial needs. A patient receiving mechanical ventilation often experiences physical and emotional stress. In addition to the problem related to critical care patients, the patient supported by a mechanical ventilator is unable to speak, eat, move, or breathe normally. Tubes and machines can cause fear and anxiety. Usual activities of daily living such as eating, elimination, and coughing, are extremely complicated. Feeling safe is an overpowering need of patient on mechanical ventilation. In addition, 4 related needs include the need to know information, the need to regain control, the need to hope, and the need to trust. When patients' needs are met, they feel safe. Encourage hope as appropriate and build trusting relationships with both the patient and caregiver. Involve patients and caregivers in decision-making as much as possible. Patients receiving positive pressure ventilation may require sedation, example propofol, and/or analgesia, example fentanyl, to facilitate optimal ventilation. Before starting sedation or analgesia in a mechanically ventilated patient who is agitated or anxious, identify the cause of distress. Common problems that can result in patient agitation or anxiety include positive pressure ventilation, nutritional deficits, pain, hypoxemia, hypercapnia, drugs, and environmental stresses, like sleep deprivation. Delirium is an acute change in mental status. It is a marker of cerebral insufficiency and associated with longer hospital stays and higher mortality rates. Intensive care unit patients are particularly vulnerable to delirium. Assess for delirium using a valid tool, initiate prevention strategies, and recognize and treat delirium when it occurs. At times, the decision is made to paralyze the patient with neuromuscular blocking agent like cistercurium, to provide more effective synchrony with the ventilator and improve oxygenation. Remember that the paralyzed patient can hear, see, and feel. It is essential to give intravenous sedation and analgesia concurrently when the patient is paralyzed. Monitoring patients receiving these drugs is challenging. Assess the patient using train of 4/TOF, peripheral nerve stimulation, psychologic signs of pain or anxiety, life changes in heart rate and blood pressure, and ventilator synchrony. The train of 4 assessment involves using a peripheral nerve stimulator to deliver 4 successive stimulating currents to elicit muscle twitches. The number of twitches varies with the percentage of neuromuscular blockade. The usual goal is 1 or 2 twitches out of 4. Non-invasive electroencephalogram technology example, bispectral index monitoring (BIS), may be useful and can help guide sedative and analgesics therapy in these patients. Excessive administration of neuromuscular blocking agents may predispose the patient problem paralysis and muscle weakness, even after these agents are stopped. Many patients have few memories of their time in the intensive care unit, whereas others remember vivid details. Although appearing to be asleep, sedated, or paralyzed, patients may be aware of their surroundings, and you should always address them as if they are awake and alert. Ventilator disconnection or malfunction. Mechanical ventilation may become disconnected or malfunction. When turned on and operative, alarms alert you to problems. Most deaths from accidental ventilator disconnection occurs while the alarm is off. Most accidental disconnections in critical care settings are discovered by low-pressure alarms. The most frequent site for disconnection is between the tracheal tube and the adapter. Push connections all together and then twist to secure more tightly. Be certain that this is the case. You can pause alarms, not inactive, during suctioning or removal from the ventilator, but you must reactivate them before leaving the patient's bedside. Ventilator malfunction may also occur due to several factors. Although most agencies have emergency generators in the event of a power failure and newer ventilators may have battery backup, power failure is always a possibility. Have a plan for manually ventilating all patients who depend on a ventilator. If, anytime you determine that the ventilator is malfunctioning like a failure of oxygen supply, disconnect the patient from the machine and manually ventilate with a BVM and 100% of oxygenations until the ventilator is fixed or replaced.